November is Epilepsy Awareness Month. Epilepsy is a condition known as a seizure disorder. Seizure disorders are actually pretty common. They're the fourth most common neurological disorder. During November, we hope to bring awareness about this condition. We hope to bring some additional education to the public about seizures because a lot of people think all seizures involve convulsions or generalized shaking in it, and they don't. They don't. Seizures can look a lot of different ways. Also, our patients who have seizure disorder, there's also a lot of things that impact them daily. They have difficulty often maintaining employment. Some of them have phobias about going out into public. Imagine having a seizure during which you are not in control of your body. For many of us, that would be quite terrifying. Good news is seizures are treatable. They are treatable. And most people can lead functional lives. However, there still is impairment that goes along with this disorder. And some people may be so impaired that they may have to seek disability. During November, we take pride in making sure that we speak on behalf of our patients. You may know someone with a seizure disorder. You may know someone who has a seizure disorder who would never share with you that they have a seizure disorder because there's so much stigma that goes along with this diagnosis. What this video aims to do is bring awareness. What this video is not is a replacement for your healthcare provider. There is absolutely no replacement for your healthcare provider. All patients are different. All seizures are different. There are different types of seizures. You might think of some questions that you might want to go forth and ask your healthcare provider after watching this video. But please do ask your healthcare provider if any of these things that we talk about might be something that is pertinent to you. This video is not medical advice. We do not claim to treat anyone other than those patients that we care for daily, that are our own patients. Let's get into it. Thanks for being on here today. I'm excited
Thank you,
to
Eva.
have our guest today. This first episode is done in the spirit of epilepsy awareness. We are three healthcare providers who work with epilepsy patients every day, and we have done so for many, many years. But first, I'll start off with our introductions, and I'll start with Kim, if you want to go first.
Okay.
How long have you been an epilepsy nurse? And how did you find your way into this specialty?
So, let's see, I've been an epilepsy nurse for almost 28 years. I started working in an epilepsy center as a unit clerk because I was still an undecided major in college. And when I started working in the unit, I thought I really like healthcare. Maybe I'll go into nursing. So I decided to pursue nursing, and I worked in that same unit as a patient care technician as I was going through nursing school. And then when I graduated, I remained in the unit, and that's where I currently work. So I have been in the unit in just about every capacity: a unit clerk, a patient care technician, a registered nurse, and now the charge nurse.
Excellent. So, Veronica, what about you? How did you find your way into the epilepsy monitoring
Um,
unit?
well, my background was pediatric nursing for most of my career. I've been a nurse for 30 years. Then I went to work in a pediatric ICU, and I saw kids with epilepsy and seizures on the general floor, but I saw the ones that were in status more when I was working in the pediatric ICU. And then there was an opportunity that opened up in the epilepsy monitoring unit in the hospital I'm at. And I thought it was interesting. And I always like taking care of those patients downstairs and trying to figure out, what does this EEG thing mean? What is this thing they're putting on my patient? So when that opening came available, I switched upstairs and went to the epilepsy monitoring unit. I've been there for 7 years.
Awesome. Awesome. And for everybody, I'm Dr. Morehill. I'm an epilepsy doctor, and gosh, I started in epilepsy in 2012, and now I'm the chief of epilepsy, so that's quite a journey too. But you know, our patients are very special to us, and it definitely takes a team effort for sure. And one of the things that you guys have mentioned is the epilepsy monitoring unit. So let's just start off, I think, with talking about what the epilepsy monitoring unit is for, and because that's mainly where both of you encounter epilepsy patients. So let's talk about like what that unit is for.
So, our unit is a level 4 comprehensive epilepsy center. And when I say comprehensive, that means that we offer the full array of epilepsy monitoring all the way to surgical intervention, which can lead to brain surgery or the implantation of a device. So, our unit is a 6-bed unit. We have both pediatric and adult patients, which makes it a very unique unit because I believe that most epilepsy monitoring units, their patients are divided. There's an adult side and a pediatric side, but we actually have a combination of both. So, being a level 4 epilepsy center, it's very unique, so to speak.
Right. You know, I think the main thing about the epilepsy monitoring unit is the patients are they're not used to the physician actually wanting to see a seizure. You know, they come
Right.
in with the hopes of seeing the seizure, usually at home. Definitely, they do not want those to occur, but we learned so much from being able to see patients have seizures with an EEG on their head. We can determine a lot about what next steps need to happen, right? And so we see very complex patients that are adult and pediatric because we're level 4 for both pediatric and adult epilepsy. What are some other things that people might come into the epilepsy monitoring unit for? So sometimes it's drug resistant epilepsy. We want to confirm their diagnosis. So we'll need to see a seizure and talk about next steps. But what are some other things that you guys have seen patients come into the epilepsy monitoring unit for?
Sometimes we have patients that come in that are having events that appear to be seizures to them, to others that are around them. But once we place the EEG on them and they have an event, we discover that there is not an electrical component from the brain with this. And it's more of a disconnect between their mind and their body. And so they have movements that mimic epilepsy or seizure-like activity, but there's no electrical changes on the EEG. And so they get a different diagnosis from that. It's not epilepsy. It's either psychogenic, non-epilepsy seizures, or you might call it functional neurological disorder.
Right, right. So some people definitely dissociate, right? They have these events that are not necessarily coming from like abnormal electrical brain activity. So yeah, people will come into our epilepsy monitoring unit for characterization as well. So when we think about epilepsy and seizures, well, a lot of patients might want to know, and the goal of being here today is kind of to answer some of those questions that patients might want to ask us. You know, we definitely have rocking chairs in our epilepsy monitoring unit, and I often sit down in those rocking chairs just because you want to give that patient the time to, you know, express themselves and get all their questions out. But sometimes patients may not ask the questions, but they definitely want to know. So one of the main things people might ask is epilepsy and seizures, are they the same thing? They have a lot of questions about if they can work, if they can drive, you know, and what to tell people when they have seizure disorder. What do you actually tell your employer? What do you tell your family? So hopefully through this chat we'll get through some of those questions. But what do you think as an epilepsy nurse would be the one of the biggest questions that patients would have for you that we can go ahead and address?
I think a common question is one that you've already addressed: is epilepsy and seizures the same thing?
Mm-hmm.
If you have a seizure disorder, does that mean you have epilepsy? And so I often tell patients that the diagnosis of epilepsy is when you have two or more unprovoked seizures. And so if they obviously have a history of seizures, their own medication, we've seen those changes on the EEG, then I tell them, yes, you do have epilepsy and you have seizures, but your diagnosis, your official diagnosis is epilepsy.
Right.
And then, of course, that takes you down a road of so many other questions. Do I have to take medications my whole life? Will I ever be able to drive? What do I tell my family and friends to do when I have a seizure? So there's a lot of questions that come along with that diagnosis.
Right, definitely. One of the things I think we commonly see in the outpatient clinic is sometimes patients might come in and they may have had a seizure secondary to something else.
Right.
It seems like with all the new waves of street illicit drugs that are out there, sometimes we see patients coming in who have had a seizure that may not necessarily be a seizure disorder, right? And the seizure disorder would just mean that they have a higher likelihood, without any other external factors, they have a higher likelihood of having continued events. And so those are the people that we focus on and the people that we treat. A lot of some of the patients who may have withdrawal from substances, or they've used some new street drug with unknown risk and side effects, might have a seizure that may not be an underlying seizure disorder. So I think the biggest thing is it's going to require a lot of evaluation with the physician, right, and a healthcare team to get down to the bottom of it. So if a patient has been diagnosed with epilepsy, the driving thing is a big thing that you mentioned. Driving, because that really impacts their ability to be functional and to work and to lead pretty much a normal life. That is definitely first and foremost with the safety counseling that we give to patients who have a seizure disorder.
Something I was going to say that I thought would be fun is that on the patient's board, sometimes we put on their carpe diem, which is Latin for seize the day. Just like a little fun fact, because I'm like you, I just want to make this light and
right.
Okay.
Yeah.
Anyway. Okay. Little side note. Okay. All right. So we're recording. All right. Back in character.
No, but I think that was good. I think we need to stay out of character. I think that's the.
Need to. Yeah. Get out of our heads.
Yeah.
Yes. Get out of our heads.
Yeah. Just act like we're having a conversation with each other.
Mm-hmm. Yeah. So as we go through this, I think the angle that we're going to take is if a patient could just hear us talking about epilepsy, what are the things that we would say? What are the things that maybe we take away from some of their most commonly asked questions that they have for all of us, and we'll just go at it from that sort of lighthearted angle, so that we can show the patients that we're people, number one, so they don't need to be afraid to ask their doctor or nurses or healthcare providers questions, but then also we want them to get some nuggets from this too. So when we talk about the epilepsy monitoring unit, there are a lot of different reasons why somebody may come to the epilepsy monitoring unit. So there isn't just one pathway that patients will come through their own. What are some of the reasons that you guys have seen patients come into our epilepsy monitoring unit? What are some of the reasons that a physician might order that test?
I think confirmation of a diagnosis. And so that's what I tell patients when we call them prior to their admission. And they're very kind of eager, apprehensive about coming in. But I always try to reaffirm them that this is the first step in getting the correct diagnosis. Is this epilepsy? Is this something else? Is this cardiac related? Could this
Right.
be psych related? Um, so I think just reassuring them that they're coming for a confirmed diagnosis is the first step in their treatment plan. Let's first see, is this epilepsy? And if it is, what type of seizures are you having? What is the best medication for you to be put on? What is the best treatment moving forward? Is surgery an option? An implanted device? But certainly the beginning is just confirmation of a diagnosis.
Right.
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 Mhm.
And I think sometimes with a new diagnosis like epilepsy, patients need to know what to look out for. Because certainly I've seen patients who may have had a seizure that ended up being convulsive by the end of it, but they may have smaller
Mhm.
seizures that may not cause that much dysfunction that they might fail to recognize. So oftentimes when you're in a epilepsy monitoring unit, characterization is a big thing too, because whether they press the button or not, we can say, that event that you had right here, that was a seizure. You need to count those, right? And so I think it
Mhm.
helps too at the beginning of their care for them also to know what to look out for because they're learning in real time what this epilepsy condition means for them, right? So
Right.
characterization's a big one. What about you, Veronica? What's some reasons that you've seen some patients coming into the epilepsy monitoring unit for?
Well, I've seen them come in because they're having movements in their body that mimic epilepsy. That someone that doesn't understand epilepsy or what seizures look like may think that they're having a seizure. But once we place them on the EEG and they have one of those events, we see there are no electrical changes in the EEG. So we're able to explain to them that what this event is doing is not seizure related, that it may be something psychological, maybe they've had a trauma in their past, they've got some PTSD, and then we're able to work through some of that with them. And because that's one of my passions is when they come in and they get diagnosed with this, I love to try to talk to them to find out what their backgrounds are, and if they're honest with you, which some people are and some people aren't, I'll be honest. um, from what I've seen, we were able to gear them in the right direction of seeing more mental health physicians that can help them with that, with different
Yeah.
therapies.
I think the biggest thing with a lot of that is with that disorder in particular is sometimes patients don't see the connections between some of the past traumas that they've had and the here and now.
Right.
I think
Right.
most people try to,
Hmm.
shove it into a dark pocket of your conscience and not
Yes.
deal with it
Yes.
until you're at home alone in your private, areas where
Right.
you can feel all those feelings and let all that out.
Right.
But sometimes people
Yeah. I
just
can't
don't
tell
see
you.
that connection.
Right. I can't tell you how many times I've had a patient say that stuff happened when I was very small. I was a child.
Right.
Why is this affecting me now? And sometimes we don't know. Is it some kind of trigger? Is it a smell? Is it a phrase that you hear somebody use that maybe brings back those emotions that you thought you had dealt with and you
Mm-hmm.
thought you were over? And then for whatever reason, those emotions and feelings come back up again, and it
Yeah.
causes them to have a reaction in their body.
Right.
Yeah, I think that's why it's important to kind of delve into their history. Do you have a history
Mhm.
of abuse? Do you have any past psychological trauma? Because sometimes just asking that question and knowing that can help
Mhm.
too.
Right.
And they don't realize where those questions are going, but we do as healthcare workers,
Right.
especially if we hear a history from a patient that you're really not clear if these are seizures or not. So I think it's important to know kind of every aspect of their past medical care, traumas, histories. All those things are so important in coming to a conclusive diagnosis.
Right.
Right. When we bring our patients into the unit, we call them and get a history before they come in, and we ask them, what are your seizures? What do your events look like? Describe them to me. What if somebody told you that they look like? How long do they last? What are some of the things that cause your seizures to happen. And being epilepsy monitoring unit nurses, we know what normal seizures should look like, how long they should be, and what typically causes most seizures. And so if we hear other things that they say, we know those are kind of red flags to ask further questions if they answer them a different way.
Right. Right. And I think some of the patients also come in for observation. So sometimes as a physician, a epileptologist, we may have a pregnant woman who may be referred over for spells, right? And in some patients, you do not have the luxury to wait for an outpatient. You do not have the time to wait until another time at some future date to admit them, to bring them in, to see their events, to get down to the bottom of it, to decide treatment versus not no treatment, or what even is this. So that's one of the more pressing examples that might come into our epilepsy monitoring unit. But some of the other patients might come in there for treatment observation as well, especially sometimes patients who have focal with impaired awareness seizures, and sometimes they may have difficulty even knowing, are you having an event, are you having events at night, are you having events in general. So sometimes kind of doing an epilepsy monitoring unit to conceptualize what's going on with them in their home state is a good thing to do as well.
That's interesting you brought that up, because I've actually seen people that are admitted that will say, I don't think these are seizures. I don't fall down. I don't shake all over. I think there's this big misconception that all seizures are where you fall, you shake, when in fact there are different types of epilepsy. And so I always find that very interesting. And then, of course, sometimes they are seizures and the patients are shocked. And, of course, that's when you really have to start educating them about the different types of epilepsy. So I have seen a few people that would come in and say, I just don't think these are seizures. They don't fit that mold, but indeed they are.
Right.
Yeah.
The interesting thing about the brain is it controls so many functions, right? And so depending upon where your seizures are coming from in terms of location on your brain, or whether they're generalized, seizures can look of so many different ways. So I think that's probably also a reason why a lot of our patients fail to be diagnosed sooner, is because they're having some event that possibly isn't a convulsion. Because if it's a convulsion, everybody's going to say, okay, that's a seizure. Convulsion equals seizure to most people in the lay community. But if there's some other event where your patient's maybe just like staring off and unresponsive, well, a lot of lay people may not know that could be a seizure.
Right. Or picking at their clothes, or walking around aimlessly and don't answer your questions, or doing some weird movement with their mouth that's repetitive.
Right. Or a gelastic seizure. I've talked with a patient who told me that she had this unusual laugh and she had never been diagnosed. And Veronica, you and I were working together, and I looked over at Veronica and I said, Veronica, I think this patient has gelastic seizures. She had never been diagnosed, but it was just gelastic seizures. For those of you that don't know, one of the components is that they laugh. And so that's what she described to me, but she had never been diagnosed. And sure enough, that was her diagnosis.
Right. So I think in the epilepsy monitoring unit, it's not uncommon to hear lots of different types of stories about how people have been diagnosed and how long it took for them to be diagnosed. And even sometimes people carry a diagnosis of epilepsy, and in the epilepsy monitoring unit, we find that they don't have epilepsy at all. Some of those cardiac cases with kind of asystole and convulsions that may happen secondary to asystole. Those are usually the most striking cases of different diagnoses that have erroneously been put under the category of a seizure disorder or epilepsy that are not, in fact, caused by a seizure disorder at all. And those patients are always overwhelmingly thankful that this is finally found so that they can get on to the proper treatment for their particular condition.
That's right.
So we've all seen patients who come in with a new diagnosis of epilepsy. What do you say to those patients? I mean, certainly getting a diagnosis of epilepsy, we see epilepsy and seizure disorder every day, all day. But for that patient, their life is instantly changing. So as a healthcare provider, an epilepsy nurse, and an epilepsy monitoring unit, what are some things that maybe you might say to somebody who is worried about their new diagnosis of epilepsy and maybe their quality of life? How are they supposed to work with these conditions? What would you say to that person?
That they are have a lot of concerns about, can I still work, and can I drive, and or will my medications affect me cognitively with my memory, and all of those are kind of individual cases, because if you have somebody who has a certain type of seizure that is well controlled with medication, and we're able to bring them in and see where the seizures start, see what kind of seizures they are, and we put them on the right medication, then we're hoping that they're going to be functional. They'll be able to work. They won't be able to drive. Will not be able to drive, most likely, depending on what state they're in, with not being able to drive, because, of course, that puts them at risk to themselves and others when operating heavy equipment or machinery, as we like to tell them they are not allowed to do. Some states are 6 months. Some states and some of our doctors recommend that they wait even longer than that, just to make sure that they're safe to drive. So they are going to have to come up with other options on how to get back and forth to work. But, with all the stay-at-home jobs that are available nowadays, then hopefully that's an option for them in order for them to have an income and a job.
For the females that come in, I think some of the common questions are, can I still get pregnant? Will I pass this on to my child? And in the pediatric population, I think a lot of questions that come up are, especially with kids that are in high school, is still, can I still participate in sports? Can I still run track? Can I still play softball? Can I still play football? And of course, these are questions that we encourage our patients to ask their physicians, because that's all dependent too on their type of seizures, their triggers. But certainly there's a lot of questions that do come up once they receive the diagnosis. And it's all relevant to them. And, are they currently working? What type of work do they do? Where are they in their life? Are they in their childbearing years? So it's really all relevant to where they are in their life.
Yeah. So one of the things, Kim, that you brought up was triggers. Triggers is a big one, because I think that's one of the initial things that patients who have a seizure disorder that they learn to work around is, how do I achieve the best seizure control possible for their individual body? And each patient, each body is different, but there can be certainly common triggers like sleep deprivation. The funny thing is, some of the patients always say, oh, when I'm stressed, I have more seizures. And I think for some of the younger physicians, they might equate stress with non-epileptic events, right? But stress to the point where it causes physiological, a physiological weight on that patient can certainly increase that person's risk of seizures at any particular point. So what other triggers have you guys seen? I know in the epilepsy monitoring unit, we certainly do sleep deprivation on 2 of the 4 nights that they're admitted with us, because we want to bring out any seizures during the short amount of time that we have with them. Have you heard patients comment on any other triggers that might kind of increase their risk of having a seizure at any particular point?
Yes, missing medication. That is so incredibly important, because and not just with epilepsy, it's just with any medical condition.
Mm-hmm.
You're prescribed a medication, you take it, you get better, you think, wow, well, maybe I don't need that medicine, or maybe I can just skip tonight's medicine because it makes me tired. And that is not the case. You have to be consistent with taking your medication. And I always tell patients too, make sure you time your seizure medications 12 hours apart. You get the best efficacy if you stay on a timed schedule. So for me, that seems to be what triggers a lot, is when patients miss their medications. I cannot emphasize how incredibly important that is. And also involving the family so that there's accountability.
Right.
That there's someone supervising the patient, making sure that they take their medications. And then, of course, there's all these other things like sleep deprivation, heat can certainly, patients report heat can precipitate their seizures. But the most important is not missing your medication.
Yeah. Well, then we also see, of course, flashing lights, but we do see that can cause seizures. So we do that while they're in our unit. And we do the hyperventilation where we have them breathe fast for 3 minutes. And we have seen patients that will cause a seizure, or changes in their EEG that would precipitate into a seizure. And also, a lot of people don't realize this, but when you're sick, sometimes, like if you have a virus, a cold, a stomach bug, or anything like that, sometimes that can precipitate a seizure. It lowers your seizure threshold, and your system is out of whack, and sometimes you can have a breakthrough seizure with that. And a lot of patients don't realize that. I find that when I tell them that, they're surprised.
Yeah. Mm-hmm. I've even taken clinic time with some of my patients when, their prescribed dose of seizure medicine and their trough blood levels, their level of medication that's present in their body when it's checked, do not make sense together. Because checking a level is more than just, is it normal or is it abnormal? It's more of, does this dose make sense that you would have this level? And, I've even gone through and taken time out of the clinic schedule to set calendar events. I like to set calendar events for taking medication. So, no matter what type of device you use for your cell phone, you can add a calendar event that you can get to go off into perpetuity, just forever. It can go off forever at a certain time of day. And those calendars are set twice a day, typically right 12 hours apart. They can even invite one of their family members to also be on that calendar event. So not only would it go off on their phone, it can go off on the husband or wife's phone or mom's phone at the same time. But taking the medicine on time is a big, huge, huge, huge thing. And it would be probably the biggest thing I would say to, or the most important thing that I would say to a patient who has a new diagnosis with epilepsy is, please take your medicine. If there's some issue that prohibits you from taking your medicine, don't be quiet about that, right? Like the healthcare providers, we want to know if you're having a side effect, so that we can address that and maybe even switch your medicine to something that doesn't cause side effects. But taking that medicine 12 hours apart, for most of it, if it's a twice a day medicine, and taking it on time is very, very important, because in that way we don't waste time, right? We get to know, does this medicine at this dose work for you? And if that medicine doesn't work, we get to add something on or adjust it to the appropriate medicine. So we really get to move on with getting things all queued up and perfect for each patient when they will take them on time as prescribed. So if you're a new patient with epilepsy, I know that a lot of patients want to find support groups. What are some tips that you would share with somebody who wants to go and find a support group? You have to be careful of things that are found online, right? But maybe there's some reputable sources that you would direct them to, or some support groups that you would direct them to.
I tell patients when they have questions, of course, as healthcare workers, we try to answer as many as we can. But once they're discharged, for every one question we've answered, they have 10 more. And so I refer patients to the Epilepsy Foundation website. It's very informative. It starts off with the diagnosis of epilepsy. It then leads into the different types of seizures. It talks about treatment plans. So I think the Epilepsy Foundation website is a good resource, and also the International League Against Epilepsy. I looked at that website today, and that's a very informative website as well. It actually gives you different links to different YouTube videos. Again, about some of the same subject matter about, what is epilepsy? What are seizures? What are first aid treatment for seizures? So for me, I think those are two of probably the most reputable websites to look at.
That's good. What about, Veronica, how do you filter out maybe websites that might have inaccurate information? What are some places that maybe you wouldn't want to
I wouldn't tell my patients to go look on TikTok. I would tell them to avoid most YouTube channel information, just to go where Kim mentioned, that those have been checked and approved by the Epilepsy Foundation. Probably not Facebook Reels. So yeah, those places can give you false information.
So I think there's just a lot of information online, right? And there's
there is Google.
There's no checks and balances for what people can put online, and some of it can be, not medically accurate. And although patients may have been told that they have a certain disorder, they may not have a certain disorder. And the biggest thing is it needs to come from a healthcare provider, right? Somebody who does this, somebody who would have some knowledge about what patients need to know. A lot of the things that I've seen online, not only as it pertains to epilepsy, but as it pertains to a lot of other things like movement disorders, tics, tremors, all the things. There's just there's a lot. There's a lot, and I wouldn't expect a patient to be able to filter through all that to know heads or tails of what is good information and what is not. So I think it's probably good to start off with a healthcare provider at least, or to start with one of those reputable sites that you mentioned, and those are very, very good websites. So when we talk about patients being able to be functional. So what I'll do at this point is just kind of take some of those commonly asked questions that you guys gave that were great questions that epilepsy patients do ask us, and we'll just kind of go through some of them in turn. So in terms of the functionality of epilepsy patients, have you all seen, because I know if you're that patient, you could be prone to anxiety or panic attack on the day that you're diagnosed with this. Like, oh my goodness, like, what does this mean? Am I going to be able to function? Have you seen patients who are able to kind of cope with the diagnosis and still do the things and accomplish the things that they want to?
Yeah, absolutely. Absolutely. Yeah, epilepsy is a diagnosis. It does not define who you are and what you can do. Obviously, epilepsy patients that work, you want them to be in a line of work that doesn't put them at risk to be injured if they were to have a seizure. For example, cooks. I wouldn't recommend that. Somebody that you shouldn't drive, obviously. But it doesn't really have to define who you are. You learn to live with it. You learn what your triggers are. You learn to live your life with epilepsy. It does require modifications, lifestyle changes, but you can still live a very happy, productive life with this diagnosis.
Right. So there are going to be some patients who are going to have epilepsy or seizures that are difficult to treat. And some of those patients might have to pursue disability and those types of things. Or, sometimes there might be patients who might have mental or cognitive disabilities and seizures that make it very difficult for them to live and to function. But that's not the majority of patients who have epilepsy. It is definitely a smaller subset of patients who have what we call drug-resistant epilepsy, where they kind of continue to have seizures in spite, at least two optimally chosen
seizure medications, whether in combination or in monotherapy. So, most of the patients who have a seizure disorder or who have epilepsy are able to be very, very functional.
Yeah, I know a girl I met just recently, and I didn't even realize she had epilepsy. I told her what I did for a living, and she said, I actually have epilepsy, and I've been taking care of her for years. And she is a mom. She has 3 children. She works. She hasn't had a seizure in years, thank goodness, because she's on the right medication and has been taking it the right way and hasn't had any trouble. So, yeah, sometimes people are able to totally function fine, and not even people around them wouldn't even know that they had that history.
Right. And it's funny that you mentioned that. I think it's not uncommon for people around a patient who has a seizure disorder not to know, because epilepsy is one of those silent battles, I call it.
Right.
It's interesting. I was looking at the prevalence and incidence of colon cancer and breast cancer, and epilepsy is a very common disorder. It is very common, but you would be more likely to know if somebody in your circle of friends or relatives or coworkers had breast cancer or colon cancer more than you would somebody who has epilepsy, because there is still a societal phobia about having a seizure disorder, that people just don't tend to openly share that they're kind of living with and coping with this epilepsy as a silent battle. So we talked about precautions already, and we were talking about states and not being able to drive, and each state is definitely very different, but most states will say patients can't drive for at least 6 months, and sometimes it's more. And then on the physician side of that, we are not able to make any sort of determination about driving until they have met their state requirement, right? And then after they've met their state requirement, we can say if we think they can drive at the time that the state requirement has been met, or whether or not they need to wait even longer. So it's a good advice to talk with your physicians. Let's talk about some of the safety precautions otherwise, like when a patient has a seizure. If you're a family member of a patient who has a seizure, what are some things that we do in the epilepsy monitoring unit that may not be amenable to people to do at home? But how do we kind of take care of those patients in the epilepsy monitoring unit when they have a seizure? What are some things we might do?
Of course, you want to try to avoid injury. With seizures, a lot of patients will fall. So, of course, if they have an aura, which is a feeling before you have a seizure, you want to get them to safety as quickly as possible. Sit them down, lay them down, put something under their head, turn them over on their side. Do not put anything in their mouth. There is a myth that you can swallow your tongue during a seizure, and that is simply not true. So don't put anything in their mouth, because you don't want them to bite down, swallow it, and loosen anything that's tied around the neck. Of course, in the hospital, you're in a controlled environment, and we have suction equipment and oxygen.
Right.
But for people,
and we have the monitor too, that we can see when their seizures are ending. Because a lot of times, if you're at home, they can't tell when did that seizure end and when is the post-ictal phase happening, where they might be snoring or still having some different movements. But we can tell on the monitor that the seizure has ended, and this is just the phase after that. So at home, it may appear that the seizure lasts a little longer than it really is.
Yeah.
Sorry, I interjected on that part.
No, I think that's a good point. And also timing the seizure. When you get into the 3 to 5 minute mark, you want to consider maybe giving an emergency medicine, like Diastat, which is rectal Valium, or Valtoco, or Nasalium, whatever rescue medication that's been prescribed. I think the ultimate goal when someone has a seizure is safety, controlling the seizure. Certainly there are cases where you have to call 911 if the seizure lasts longer than 5 minutes, even after an emergency medication has been given, or if the patient starts having seizures back to back, or if they have respiratory issues, then certainly you want to call 911. So yes, I would say safety, stopping the seizure is probably two of the most important things. So you just have to give them kind of guidelines on how to do that.
Right. So I think probably safety, definitely. That's number one. If things are convulsive, rolling the patients onto the side. And the reason that we would recommend that is so that any saliva that's gonna, they're unable to swallow at that point, that it would just come out onto the floor.
Or vomiting too. We don't want them to vomit.
Would come out onto the floor.
That's very common.
Right. We don't want that fluid, that vomit or that saliva in the lungs. For sure. Right. And then, one of the things we might encourage them to talk with their healthcare providers about is rescue medicine. Specifically if a patient has had a history of convulsive seizures, a rescue medicine or prolonged seizures without return to baseline, or seizure clustering, where if they have one, they're going to have three, Right. So talking with the healthcare provider about getting some sort of rescue medicine is going to be certainly very, very important. And I guess as far as to call 911 or not, my take on that is kind of, as healthcare providers, we have different metrics, right? And our goal is to, help patients not have to come to the ER, because that means that their condition is severe, right? And we don't want their condition to get to that severe stage where they have to come to the ER. So we try to, give them steps in between, so that they can decrease how severe things will be at home for them. But I just always say, if it's something that you feel like you can't handle, whatever it is, call 911. The worst that can happen is they take you to the ER and you didn't need to be there, but you're safe. But we definitely want to try to keep our patients out of the ER as much as possible, because that means that we're doing a good job with controlling things at home, for sure.
Right. In our unit, though, it can be, as nurses, we're kind of sitting on the edge of our seats a lot of times when the patients get up to go to the bathroom, because we can't see. The camera only follows them while they're in the room. So when they go in the bathroom, we're depending on our EEG to tell us a lot of our information. And when they brush their teeth, sometimes that can mimic seizure activity sometimes. And for us anyway, on our end. And so we're kind of sitting, because we really do not want our patients to get hurt, of course.
Right.
And so sometimes we have patients that we even have to go in with them to make sure they're safe. We don't allow them to get up by themselves.
So I think patients should call 911 if ever there's anything that, or the family should call 911 if ever there's anything that is outside of their comfort to handle at home, whatever it is. Or if the patient appears not to be breathing well, or if the patient appears not to have good circulation, if they're like turning gray or blue, or if the seizures are prolonged, or if it's a first seizure, if it's a new onset seizure, you should definitely kind of call 911 and get them in to be seen. Sometimes with patients who have seizures, epilepsy is a very chronic condition, and if the seizure follows its pattern and you've had that seizure 10 times before and it's stopping in a reasonable amount of time, and you have rescue medicine on hand, some of those patients definitely might choose not to call 911, but just to keep it and talk with their doctor about it. So in terms of how the diagnosis might impact family planning, what are some things you might say to maybe a woman who has childbearing potential, or there are other people in our society who may not identify as women, who may not use the pronoun she or her, who might have childbearing potential? What do we say to those patients who have childbearing potential, regardless of how they identify, about family planning? What are some things that we would recommend for them to consider, at least? And maybe it's just talking points for the patient so that they can go and have a further conversation with their doctor.
Right. I would recommend that they find an epileptologist that specializes in patients who are of childbearing years that have the potential to get pregnant. Because number one, you want to be on a medication that's not harmful to the fetus. You want to be on the right medication for your type of seizures. So it's, I think, finding an epileptologist that specializes in that can answer all the questions that they have. And I recommend doing that before they consider getting pregnant.
Definitely. Yes. Yes.
That
And
is
also we've had a lot of patients that are of childbearing years where it would be a possibility of a unplanned pregnancy, and they go ahead and take folic acid every day so that they already have that on board if that were to happen. So I think that's also important.
I think the biggest thing is you mentioned talking with the provider before conception. That's so important because from a physician standpoint, we would definitely want to make sure that we've queued things up as best as we can, that the patient is controlled. Ideally, if their seizure frequency is already down to 0 and they're on stable medicines and we have levels for those medicines, like that's a win for everybody. It's unfortunate when patients may be referred to epileptologists after pregnancy or after pregnancy has already occurred, especially if those patients are not seizure free. Because it really limits that treating physician at that point to kind of make an impact, a meaningful impact. And a lot of things happen with the developing fetus even before people know that they're pregnant. So taking that folic acid ahead of time and being on good medicine ahead of time, as opposed to medicine that might be black box listed during pregnancy, like valproic acid.
Right.
There's some others, obviously, that are not necessarily considered great during pregnancy. But it's definitely better for the patient and the developing child inside the fetus that mom be referred over to the healthcare provider, epileptologist, if at all possible, prior to conception. So misconceptions. So there's a lot of misconceptions about seizure disorder, and we've kind of talked about the functional life one, whether or not most of the patients can have a functional life. What are some other misconceptions that maybe you've encountered? I know one that I've encountered is that sometimes people, I feel, our patients may not take their medications regularly because they don't realize that they could have a bad outcome, right? They could have a very, very bad outcome if they don't take their medications, and that there can be this condition known as SUDEP, sudden unexpected death, that can result secondary to epilepsy in an epilepsy patient. And that risk of SUDEP is increased by more than 10 times in patients who have uncontrolled convulsive seizures, right? So I think it's that's something that I wish patients knew a little bit more about, so that they can make better choices with regards to their medications and triggers. What are some misconceptions that you've encountered? I know you talked about the spoon in the mouth. That's an old wives thing, I think, that used to happen. I hope that's not happening anymore.
Right.
I don't hear that as much anymore, but we do go ahead and say it just in case.
Right. Yeah.
What about recovery from brain surgery? There's a big misconception about brain surgery for epilepsy specifically, and what that entails.
I think a common question with that is, I don't want to have brain surgery because I won't be able to walk or talk after surgery.
Right.
And so I always tell patients that their outcome dictates our outcome. We wouldn't even offer surgery if we thought that in any way your ability to talk or walk was impaired.
Right.
That's not our end goal. We want you to be seizure free and have the same capabilities that you have now. Mm-hmm. So I think that's a huge misconception. And they also think that, and I'm no neurosurgeon, but they think that they're taking like a big chunk of their brain out, when in fact, it is such a tiny little piece. And
Right.
again, that information would come with a consultation with a neurosurgeon. But people think that they won't be able to walk or talk after having epilepsy surgery, and that they're going to remove a large portion of their brain. And
Yeah, and they
so,
also think they're going to be in the hospital for a long time, which is
yeah.
not true. It's usually only a few days, if that.
Hmm.
It's a very quick recovery, usually, surprisingly, considering
Yeah.
they're cutting the brain.
Yeah.
Right.
It is a very quick recovery. It's funny. You would think, brain surgery. It
Mhm.
sounds very scary, right? Just to say
Right.
it, or to admit that you need it sounds very, very scary. And
Yeah,
all
a lot of people when
surgeries,
they first hear that, they say, "Oh, I'm not going to have
right,
brain. I don't want to do that."
right.
Yeah,
And I think, certainly there's some reasons that could be scary that people have brain surgery. And I think every surgery is serious. Disclaimer: every surgery is serious, and every surgery you should weigh the risk benefits, and you should only proceed if you absolutely need it. However, when you think about relatively somebody who has brain surgery and the recovery from that versus somebody who has open heart surgery and the recovery for that, or even some of these abdominal surgeries and the recovery from that, having brain surgery, the area it tends not to be very painful either after, in terms of the
right.
post-op. Like, they might have that initial headache that happens day one post-op that tends to get better into day two post-op, but then those patients, they look surprisingly very great to say that they've had brain surgery. So that's definitely a misconception that a lot of our epilepsy patients have, is that they are just going to be overwhelmingly impaired after brain surgery. And I think patients tend to be overwhelmingly impaired more in terms of physically the pain after they have like a thoracic or abdominal or some sort of orthopedic surgery than
Mhm.
they do with our epilepsy surgery.
So I'm a big proponent of epilepsy surgery, just because I've seen during my 28-year career the number of epilepsy patients that are actually seizure free after surgery. And and so I'm a big proponent. And so I think sometimes just mentioning epilepsy surgery, and I always tell my patients, I say, this is food for thought. Okay, just go home, think about it, do some research, but don't rule it out. Don't rule it out, because it might be the best treatment plan for you. And I think once you introduce that concept, it kind of opens their mind, and they're not so opposed to it. And
Right.
and then I always tell them, just because I've seen so many patients that are seizure free after having epilepsy surgery, and ultimately that's what everyone wants.
Mm-hmm. I guess if you think about drug resistant epilepsy, one thing that may not be intuitive to patients is that there's more than just medicines that we have to offer, right? And so, as a healthcare provider, or your physician, or your epileptologist, they're going to make sure that you're on the correct medication. And this kind of opens up the what do you do when seizures don't stop question, right? In terms of chronic epilepsy, not status epilepticus, which is something totally different. That's a medical emergency. You'll be in the ICU for that, definitely. But what do you do when seizures don't respond to medications appropriately, in terms of you're on two medications and you continue to have seizures, and those medications are optimal for you? You're on a good dose of those medications. What do you do in epilepsy surgery and implantable devices? Those
Right.
non-pharmacological treatments, that's what we would call it. And basically that means all non-medication options would be what we would want to explore next. And that might require a lot of workup, but patients are still able to achieve seizure freedom sometimes. It just depends. I think your point brings into consideration drug resistant epilepsy. What do you do when patients who are having chronic seizures, not status epilepticus, that needs to be treated in the ICU, but what do you do when patients have status epilepticus, have chronic outpatient seizures, and those seizures are not stopping? So drug-resistant epilepsy really is when patients are on at least 2 medications at optimal dosages for them. So that means optimal, maximal tolerated doses for that particular patient, whether in combination or in monotherapy. And that definition comes from the International League Against Epilepsy. So when those patients have drug-resistant epilepsy, what next? And epilepsy surgery and non-medication options could be the thing that is needed next in those patients. So it's important that we talk about these misconceptions, right? Because we wouldn't want somebody to miss out on an opportunity to be cured of epilepsy with epilepsy surgery, or to certainly have a meaningful seizure reduction. So we talked a lot about what to do during a seizure, but what are some things that patients should not be doing, or their caregivers shouldn't be doing to patients when they're having a seizure?
I think not holding them down. Don't forcefully hold them down. Sometimes with tonic-clonic seizures, you have stiffening and shaking of the extremities. So try not to hold them down. Don't be forceful with them. Again, do not put anything in their mouth that they could bite down on and swallow. You don't want them to aspirate. And then lastly, do not offer them any type of medication or water or food until they're fully alert, because you don't want them to aspirate,
Right.
which means, it would go in their lungs. So certainly those things are important things not to do when you're having a seizure.
Right. So we definitely want to make sure that the patient can swallow on their own before we offer
Yeah.
them any food or drink after a seizure or during a seizure. Well, good. So I guess the final question for you all, we certainly see epilepsy patients often. That's our everyday task, is taking care of them and helping them to get to seizure freedom if we can, or improve their quality of life if we can with our treatments. So what are some things that maybe you would say that you've learned from your epilepsy patients over the years? What is the biggest thing that you would say that they've taught you?
I can answer that. They have taught me that even though they have epilepsy, life can still go on. And just like that person that I talked about earlier, that I didn't even realize she had epilepsy, that didn't define her. She was a mama, she's a wife, out in the workforce, and that it was something she didn't even bring up in conversation until I mentioned what I did for a living. And so I would say that we have a lot of patients that come into our unit that have that same mentality, that they don't let that define them, and that's kind of taught me that you can have a normal life, you can keep living, and you don't have to have all of your focus on that. It is something that is a part of their life, and they have to be aware of it, but it doesn't have to define them.
I would agree with you, Veronica. It's a diagnosis. It doesn't define who they are, and they can still live a very productive life. We see engineers that have epilepsy. We see nurses that have epilepsy. Of course, lifestyle modifications have to be made, but they can still live a very productive life.
Right. So I guess for me, I think one of the biggest things that those patients have taught me is, wow, they're so brave, right?
Mm-hmm.
I see the way that they continue to live life in spite this condition, right? Because one could literally draw up into, and just pull back from the world out of fear of going out, or fear of having this seen at work. Epilepsy is a condition in which, sometimes if a seizure happens in public, that person is not in control of their body or their bodily functions,
Mm-hmm.
such as, their ability to maintain continence of urine and bowel. So these patients are incredibly brave, and courageous to go through life and fight this disease, and continue to try to live normal functional lives in spite of the condition. And I think by and large they really give us strength, I feel, to continue to do what we do, because we want to see them achieve their best self. And so if there was something that I had to say to an epilepsy patient, it is, this is a diagnosis, but most diagnoses are treatable, right? And with the help of the correct healthcare provider team, including your neurologist or epileptologist and your epilepsy center, you should be able to at least have some level of quality of life. There are some patients that have a lower level of quality of life and may have drug-resistant epilepsy. We see you, and we understand those battles too. But for most of our patients, we can make things better. So if you have questions, ask them. Find the correct sources to find your information from. Probably Facebook and TikTok is not the correct places to find that information. And make a list of things that you want to ask to your healthcare provider. And have those, take the time to have those chats. And if you find that your healthcare provider's not listening to you, there's a couple things you can do. Bring somebody along with you to help you stay focused to ask your questions. Sometimes with healthcare providers, if you are the last patient and they're not rushing off to get to somebody else, they will take more time. And, if you're not finding the answers that you need even still, you might have to see some other folks, add some other providers to the team to help you get the care that you need. But I've just learned so much, and the biggest thing is just, wow, these patients are so courageous, and we just want to see them fight their fight, and we want to help as much as we can. Well, good. So I guess that's it for us. Thank you guys for being here. Thanks for taking the time
Thank you for having us.
to chat.